I'm Dennis Daly from Pittsburgh, the director of the Appalachian Tri-State Node of the Clinical Trials Network, and I've been involved in treatment of addiction and co-occurring for decades, and have done a lot of clinical work with families as well as individuals, so it's a pleasure to be here.
I'm John Hamilton. I've been involved with the Clinical Trials Network from the beginning, and I'm involved in the New England Consortium, and had been involved as chairing the dissemination committee at one point, presently on the steering committee, and am involved in, had been involved in two of the blending products early on, the Mia Step and the PAMI, and have really enjoyed my relationship with that I've built with researchers and other clinicians around the country, developing evidence-based practices as a result of the CTN.
Okay, well, it's a pleasure to work with John. I think John is an incredible professional in terms of not only running a large continuum of services, but like me and a lot of others, he still likes to see patients and families, which I really think is a great idea. Now, this is called Family Involvement in Substance Use Disorder, Mental Health Treatment and Research, but the main focus will be more related to substance use disorders. And what we want to do is discuss the impact of these disorders on the family units or systems, as well as individual members, including children. We want to talk about strategies and challenges for patients to address family issues when they're in treatment for their substance use disorder or involved in recovery. We'll review interventions to help families, and then at the end we'll have a discussion of what you think, what we all think might be some interesting ideas for research for families, some potential research questions or areas. So the first objective will be to look at the impact of disorders on the family and marital systems and individual members, including children. And I want to point out that all families are not affected in the same way. The actual effects are mediated by a number of factors, and these would include specific things such as the severity of the substance use disorder, the behavior of the affected family member. So, for example, if someone's violent or suicidal, that will have a different impact on the family than if they're not. The presence of comorbidity, it could be psychiatric comorbidity, it could be a serious medical problem, it could be social comorbidity. The support that the family members receive within and outside the family, and also the psychological coping strategies or resiliencies of family members. And, as many of you know, if you've been around for a long time, we've thrown around terms like codependence, and we've put these negative labels on families, and I think we have to be careful about that because there's a lot of folks who have been affected adversely, but they have great resiliency skills. So if you look at these disorders, they're no different than other disorders, behavioral health disorders. They run in families. In fact, there are many different studies of children that show that if a biological parent has an alcohol or drug problem, they're at an increased risk themselves. And that's similar with other disorders. We have an example here of mood disorders in twins, but you could also say this with bipolar illness, schizophrenia, and some other psychiatric disorders. They do have a family component. There is a predisposition based on families. Now, having said that, that does not mean everyone in the family will get the disorder. In fact, I always find this intriguing because in my own family, I'm one of 6 kids, and my father was a chronic alcoholic with psychiatric issues as well, and there were 4 out of 6 kids with addiction in my family. And then on his side of the family, there were very high rates of addiction, whereas on my mother's side, there was no addiction at all. So it's always intriguing to me how families are affected differently. Now, if you look at some of the specific effects, and they would include, I think the most common, based on the clinical literature, the research, surveys we've done, surveys others have done, is the emotional distress, and it can affect the family atmosphere, what it feels to be in a specific family. People may feel angry, they may feel resentful, they may feel hostile. Anxiety and worry are common. We work with a group of parents in the past year, and some of the most common worries they expressed, and these were mainly parents of opiate-addicted young adults or teenagers, and their biggest fears were overdose death, or an overdose, or relapse, or being incarcerated, or just sort of losing their direction in life. Depression and grief are common, and you have grief because we have people who die as a result of their addiction, which has a huge impact on parents or people left behind. Guilt, shame, and embarrassment, helplessness, hopelessness. Sometimes that's part of a clinical depression, sometimes not. Chronic stress. So these are part of the emotional effects on the family, but you have other effects as well I wanted to mention. One is family instability. You have increased rates of separation and divorce, increased rates of children and youth involvement, taking away kids. And the last one I wanted to mention, which I've heard a lot more about in recent months, is the financial impact. And I gave a talk to a family group last Wednesday night, and the mother came up afterwards, and I felt bad because she has a young 22-year-old daughter that's been in multiple treatments. You know, we know this is a relapsing disease for many, and I didn't even figure this out financially, but I surmised from what she told me that they spent a fortune on treatment episodes for her daughter. And not only did they spend a fortune on the treatment episodes, but they did it at the price of not being able to take care of themselves. So the financial aspects are important as well. You know, if you look at children, addicted moms, whether you're talking about opioids or you're talking about alcohol or other drugs, it has prenatal and postnatal effects, which are adverse. There's a whole literature in this. We had mentioned kids are at higher risk for substance use disorders. There are also high rates for depression, anxiety, oppositional disorders, which show in problems getting along with other kids or problems with the legal system or problems at school, medical and academic problems. And they're more likely to be impulsive, inattentive, or irritable, and this may be because their executive functions of the brain are affected where they can't reason as well as other kids. And I do think, if I look at the field, having been in the field for decades, I think that one of the trends recently is that we have less focus on the family in textbooks, research, educational programs and conferences and workshops, and clinical services. So one of the messages I want to give people is to take a look at what do you offer for families, if anything. Should you do anything differently? Because I really think the field is losing its way, and I'm very bothered by that. And so there's a group here that have studied kids. They've studied kids for close to 30 years who've had fathers with a drug addiction, and they compared them to community controls, and they found these kids had lower IQ scores, and they don't do as well in school as well. And here's just one quote from one young kid. "My dad's addiction messed with me in lots of ways, got in trouble with the law, I almost dropped out of school." And you know that if kids don't finish school, they're less likely to be successful in terms of work or career, economic survival, and those sorts of things as well. So you have the academic effects. You also have the emotional distress, anxiety, depression in kids. So you have, if you go to psychiatric hospitals, you'll see increased rates of kids admitted for mood disorders that are children of parents who have a substance use disorder. And I think too, I don't think any kind of data can convey what it's like for a child. So if you look at some of the quotes, for example, and these are from kids we've interviewed in the past. "It made me sad and afraid. I worried something bad would happen to Dad. I felt so alone and depressed." So if you think about this from the child's point of view, you can understand how difficult it is. But you have to keep in mind too that children often do not express these feelings directly. They express it more in their affect or in their behaviors or in their academic achievement or underachievement. You also have higher rates of abuse and neglect, according to SAMHSA. Substance abuse is involved in the majority of abuse and neglect cases. So you can imagine what it's like for this little boy. And I've talked to many people over the years who have felt neglected. And in our culture, there's so much focus on physical abuse, we often minimize the impact of emotional abuse, which can be caused by not having access to one's mother and one's father. And again, addiction will take this away. So that's just a brief review of some of the adverse effects. There certainly are other ones as well, but those are some of the most common ones. And John will take it over and talk about some client barriers and some strategies related to treatment and recovery.
Thank you, Dennis. Yes, it's wonderful as family therapy as an intervention. There are still many challenges regarding clients' involvement, family involvement, and even staff that become obstacles but can be worked with to introduce it into your system of care. And so my objective that I'm going to speak on briefly is the challenges and strategies for patients and clients to address family issues in treatment and recovery. And one of the first barriers, I think Dennis had touched on it earlier, are the issues around language too for the clients and the families. Is I believe the language of recovery is more empowering, strength-based, and resiliency-based in general, except when it comes to speaking about families with such pathological terms as codependent, enabling, and dysfunctional families. I think it just adds to this kind of shame-based interventions that had historically been introduced before the evidence was there as treatment models of pointing the fingers at families who already feel like it's their fault or the individuals and their loved ones, and it became its own obstacle. So from a client's perspective of barriers, their own sense of shame and guilt over the past is a clear obstacle. They also would like to think it's their problem, and they take full responsibility for it, so they don't want to pull their families in. Again, this is misguided because they're missing the point that families need and deserve support and healing as well. There are other commitments that become a challenge, particularly for women. We find that issues around transportation and childcare become real obstacles of bringing families in. And sometimes there's just a sense of ambivalence in their recovery process, and there's something that they don't want you to know about as the clinician or the treating system that their family may expose. And like anybody, including myself, who likes being told what to do? So that becomes a big issue. So I think the overarching piece that I've seen also with clients is that they're oftentimes ambivalent when they walk into my system of care on their recovery in the stages of change model. They may be pre-contemplative and contemplative, whereas oftentimes family members are at the stage of readiness, a stage of change towards wanting to do whatever it takes to help their loved ones. But because the client is in a position where they're still on the fence of whether or not they're not quite sure if they're going to be able to have sustained their recovery, I've had candid conversations with these clients that have told me they don't want to bring their family in, only to disappoint them again if they go out and they relapse. So, next slide. Now, so there are many evidence-based practices that we already have infused in most of our treatment models, both an individual, group, matrix model, relapse prevention, and obviously marital and family therapy touches upon family issues, and it's infused in much of the programming, but oftentimes isn't specifically separated out for a family program. So I just wanted to note that people should get credit for the work they do, like the internal family systems work and the CBT work that includes family, and relapse prevention that would oftentimes include the relapse prevention and recovery management of significant other and family involvement, which becomes so key in having a person go back into the community and redefine relationships in a manner that promotes recovery for all. So we need to understand the impact of the substance abuse disorder on the family, encourage families to become educated. That becomes a key piece. First, do no harm is one of the philosophies we have in our agency, whereas if family members are not involved in being educated about what treatment and recovery is and isn't, they could inadvertently sabotage treatment. We find this particularly present in our methadone programs and medication-assisted treatment, where the individual, the client or patient would come in saying they want to come off methadone, and as we continue the conversation with them, we find it's their family members that are pressuring them to come off because they don't understand that it's a medication for their treatment, and they're uncomfortable with them being on that medication. So again, this also speaks to the fact that you don't need family therapists to do this family work. Oftentimes exactly what a family member needs is just a skilled clinician, a counselor that can educate on what recovery is, on what buprenorphine is, and what methadone is, and giving them the facts so they understand what recovery is and how to support it with their loved one. There is also involvement with family in family sessions to let them know that their recovery is independent of their loved one, and to try to get them involved in having their own support network so they don't feel alone. And then obviously in 12-step philosophy, family involvement is covered with making amends, and it oftentimes is included as the part of the making amends process. And sometimes we find that when we bring family members in, they too may need assessment and diagnosis and treatment for their own substance abuse disorder or substance use disorder or psychiatric disorder that they could also use some help with. So it's an opportunity to get everybody in the family help. So now I'm going to review the barriers and family interventions on the clinical trials, meta-analysis literature, SAMHSA's National Registry for Evidence-Based Practices. So we're going to touch upon what some of these barriers are. So, as I said earlier, boy, if this family therapy is so great, why is it used so infrequently? One of the first barriers, I believe, that I've noticed in the system, or one thing that I've noticed in the treatment field of addiction, is the bifurcated system. It's really set up in a siloed manner where private for-profit programs oftentimes are most often seeing family involvement as an expectation and treatment, and the nonprofit world, in my experience, has not had the same level of family involvement as the for-profit world. For the family involvement in the commercial clients in the for-profit world, there's a practical consideration where families come in and oftentimes will support the cost of treatment through their own commercial insurance and for sometimes an out-of-pocket copay that because their loved ones in the throes of addiction, they do not have the resources to be able to cover. So I think this is an important distinction that I've seen that in some ways has split the field for the more universal and standardized involvement of family in the entire field. So from the family's perspective, some of the barriers is they already feel like it's their fault. And sadly enough, some families have gotten some bad family therapy in the past in treatment programs years ago where they had the finger pointed to them and said it was their fault and they were enabling or they were codependent and they were dysfunctional. And it just had them feel even more shamed and guilty and not want to come involved and get yelled at because they already feel like it's their fault. And also there's the sense that family members sometimes attribute too much of a personalizing of what happens with not recognizing that relapse is part of recovery in this chronic disease. So they actually start to take it personally that how could they do this to me? I think the semantics is that oftentimes family members trust their loved ones and don't have faith in them. And it sounds like a semantic issue, but we spend a lot of time kind of having the sense that when a family member says, I trusted that you were going to come out of detox or come out of residential treatment and stay in recovery, they made it about them, and it was an unrealistic expectation versus having faith that their loved one, their client, their patient is doing the best they can with the resources and choices they see as available, and sometimes relapse is part of recovery, and it's difficult for them not to take it personally, but it's also important for them to recognize that if their loved one does relapse, their recovery process is independent of that, and they could still get the help and support that they need to be more reasonable about what healthy support is for them and their loved one. So they're unable to see how they can help the family members, so they just get frustrated. And clients sometimes advise them not to go to sessions because, again, they don't want the accountability at times. I've seen we had tracked our clients in one of our methadone programs and buprenorphine programs that our young adults were coming out at higher rates, and we thought it might have been co-occurring disorders. But when we actually dug a little deeper, we found out that the individuals that were under 23 or 24 would come in and not sign releases for their families, didn't get family involved, and they came in sometimes just managing their addiction and not their recovery in an anonymous way, and left in an anonymous way without their family ever knowing that they went for help. So now we have an expectation in our treatment programs that anyone under 24, there's an expectation of family or significant other to be involved in their treatment, and we've had a much greater significant retention rates with those individuals because now they're committed to recognize there's a higher level of accountability with their family, and that their family oftentimes give them the supports necessary to stay sustained in treatment. Now, from the staff perspective, again, some of the confusion is staff members that I've worked with feel that if they're not a licensed family therapist, they're working outside of their purview of expertise. This is not the case, as I indicated earlier, that in many cases families just need an education of addiction in general and walking them through what recovery is like, what the schedule is like, what their loved one experiences, and being able to answer questions about addiction and recovery becomes sometimes most paramount, and families being able to sign on and support the recovery process. So other staff, sometimes it tips their hand in their philosophy of care that you find that some of the staff that are maybe more confrontive than others, which we know in evidence-based practices, and our friend Bill Miller will always say confrontation doesn't work, that I've had counselors tell me, well, I can't tell the family members what to do. I can't confront them. And, of course, kind of tips the hand that it's time for more supervision and support, because they probably shouldn't be telling their clients what to do and confronting them as well. But that does become an issue. It causes too much stress and affects relapse is another myth. In fact, most of the research, as Dennis has shared earlier and will share again, is compelling arguments that family involvement will improve outcomes for all. And this frustration over the inability to get members in treatment. Sometimes staff are not comfortable trying to engage family members, and sometimes it's just a practical consideration that they live outside of the state. But my experience is when you make it an expectation of treatment and tie it into incentives, whether it's outpatient methadone residential, for take-home bottles, for completing treatment earlier, for visits, for weekend passes, you'll find you'll get family members to come in. And, of course, we look at family as anyone who is committed to the person's recovery. So it's any loved one. It could be an extended definition of family, including sponsor, employee, somebody from the faith community, anybody who's committed in that person's recovery, we will welcome and support. And the other issue, too, with staff is the issues around countertransference. It's, as the expression says, it's hard to take somebody beyond where you've gone yourself. And for some staff members that I've worked with, they've done great work maybe in their own recovery or in their own life and therapy, but they haven't touched upon their own family of origin issues. So it pushes a button for them sometimes to work with families. If they haven't done that work themselves, they need to keep that out of the work that they're doing with individuals. And again, it's the need for supervision to make sure that their issues are not interfering with their ability to treat family members with dignity and respect. Family interventions for psychiatric and substance abuse disorder. You can see the NRAP, which is the National Registry of Evidence-Based Programs and Practices. There's compelling research that shows increased engagement, retention rates for the individual, reducing family burden, and improvement among individual members. It's just compelling and significant. The science is there to show it, but we just have not had the widespread adoption of family involvement in the addiction treatment model. So, what is family therapy? Family therapy can be seen as a collection of approaches that share the belief and effectiveness of family involvement. The family systems theory is that change in any part of the system may lead to change in other parts of the system. Family therapy in substance abusers have two main purposes: to use family strength and resources to find ways to live without substances and to ameliorate the impact of substance abuse disorders on identified patient and family. Going to the family strengths point, again mentioning what Dennis said earlier about pathology and language like codependency, there had been an exercise years ago of doing genograms to show oftentimes the widespread intergenerational patterns of addiction or substance use disorder or mental illness. What we found is that is not as helpful as actually identifying with a genogram, a strength-based, resiliency-based genogram, to ask the family when doing a genogram of looking at different generations of who else had similar struggles and what did they do that was most helpful. Now you have a hopeful, strength-based, culturally competent intervention that's based on what works for that family is a great place to start. Okay. Models of family therapy and substance abuse treatment. Again, we have different models that are out there. The family disease model, which again, unfortunately includes some pathological languages such as dysfunction, but the idea of it being a transgenerational process is helpful and hopeful, but some of the language needs to be changed. Family systems is generally the overarching concept in most family models. Some CBT models, cognitive behavioral therapy models. In the last four bullets, the multidimensional, functional family therapy, multisystemic, and brief strategic family therapy are all models that are based on working with young people and intervening with young people. And again, much of this model today is happening with young adults in adolescent programs and young adult developmental models. However, in my experience with working with older adults and adults, there is not that widespread adoption of family therapy as a strategy towards working with adults in addiction and co-occurring treatment. So the goals of family therapy is to help family become aware of their own needs, to provide genuine, enduring healing for family members, really offering them hope and faith, shifting power to parental figures, empowering them not in a tyrannical manner, but with rational authority by way of their wisdom and expertise, improving communication in the family, helping family make changes to affect substance abuse, the substance abusing member, help keep the substance abusing member from moving to the next generation, which is what I mentioned earlier, that transgenerational pattern, and helping families solve problems.
Families are affected by these disorders even if they don't have a member with a disorder. And best example I can give is I have a colleague whose 6-year-old daughter and 61-year-old mother were killed in front of her on the sidewalk when a drunk driver came up on the sidewalk. And then I work with athletes, college athletes, and I wanted to point out that even one episode of drunkenness, bad things can happen. You don't even have to have an addiction or alcoholism. And I think of a young man who was well-liked, good student, good athlete, got drunk one night, decided he wanted to ring the church bell. 2 o'clock in the morning, climbed up into the crawl space in the church. He was crawling across to get to the bell to ring, and one of his teammates was behind him, and his teammate said, "Hey, Billy, let's stop, let's go back." And Billy said no, and then 3 seconds later, he saw a light and heard a thud. The young football player fell through the insulation, hit his head on a church pew, and then died within 2 days. And the reason I bring that is that if you look at what's going on in our culture currently, this is all throughout the news. You're just seeing all these episodes of drunkenness, these young people getting into severe trouble, whether it's a automobile accident, or you had the 2 athletes from Vanderbilt who recently were convicted of rape and sent to prison for decades because of getting drunk and having sex with a woman who wasn't interested. So these disorders affect everyone, not just the families with the disorder. So you have a number of family models, and one of the big issues is how do you get people in treatment, because the majority don't get treatment. Only about 10 to 15% get treatment, and most get treatment because of pressure or influence from the legal system, employers, families, or medical professionals who make referrals. And the CRAFT model is designed to get the member with the problem into treatment, and they have high success rates, as you can see with some of the data there. It also aims to get the member to stop or reduce substance use, and there's great effectiveness in terms of reducing or stopping alcohol and drug use. But very importantly, and the last point, is to help families improve or enrich their own lives. Too often in treatment, everything focuses on the patient with the substance use disorder, the mental health disorder, and not on what is it like for the family, how can we help them, how can we reduce their burden, their emotional burden, their psychological burden. And I think programs like this can make a big difference with families. If you look at family engagement interventions, there's some other ones, the ARISE model, the CRAFT I'd mentioned, brief strategic family therapy. They all show much higher rates of engagement in treatment than you have from treatment as usual. And now I haven't seen this recently, but there was only one small study, the Johnson Institute intervention model, and it didn't show much efficacy. And that's the model that was used quite often from around the country. But you do have models of engagement that do make a difference. Now, there are also a lot of studies of adolescents. This particular group here is more the adolescent therapies. In fact, the family treatment's the treatment of choice if the adolescent has a substance use disorder. And what they find is superior results of family involvement compared to other approaches. Now, that doesn't mean that other approaches don't work. They do. Family approaches work better. And so you have better outcomes with alcohol and drug use, better outcomes with school grades and pro-social behaviors, and also better outcomes with families. Families function better, they feel better, they get along better, which is very important as well. If you look at family therapies from the point of view of the member with a substance use disorder, they're more likely to stay in treatment. And as we know, time in treatment is very important. If you drop out early, you're less likely to get the benefits of treatment. then also you have the improvements in functioning and substance use, academic performance, problem behaviors, and so forth. So clearly you have benefits to families as well as the adolescents here. You also have the outcomes of family interventions with family members without a substance use disorder. So you can help a family even if the member doesn't get involved, the member with the problem. And John pointed out, and I think this is important, I'm a licensed social worker and I'm also a trained family therapist, and what I tell people is that you do not have to be a family therapist or social worker to help a family. Now that's not to say you do family therapy, but there are a lot of interventions that can make a difference. Sometimes even a 15-minute phone call or face-to-face meeting when a family comes to a rehab or detox center can make a difference. So the outcomes of some of the literature here show less conflict, improved communication within the family, and very important, people feel better. They're less angry, they're less depressed, they're less anxious. That emotional burden is reduced significantly, reduced welfare dependence as well, so people are functioning better. And then there's a literature on behavioral marital therapy as well. And this also shows when you get couples involved in treatment, lower rates of substance use, lower rates of relapses. In fact, the one model adds relapse prevention to the marital therapy, behavioral marital therapy, and that shows even better benefits. You have lower levels of domestic violence. You have reduction of HIV risk behaviors, and as you all know, that's been a major focus of the Clinical Trials Network. How can we reduce behaviors and increase the likelihood of HIV infection? And then improvement in children. And so we have lots of good therapies. I think the problem is they're often not used very much. You know, multifamily groups are used a lot, and there's more of a literature from the psychiatric side than the addiction side. But multifamily groups show positive outcomes as well, and these are just some of them. So you have, for example, better employment outcomes, reduced symptoms. You have lower psychiatric relapse rates. In fact, in psychiatry, there's a concept, everyone doesn't agree with it, it's called expressed emotion. In families in which if the families are too enmeshed with the patient, or if they're too hostile and negative, and there are well over 30 studies, mainly with schizophrenia and major mood disorders. And what they find is that when families participate in therapy and they control these emotional reactions, that there's a significant reduction in rehospitalization rates. So what that shows is the influence of the family on whether or not a patient has a recurrence of illness. Now, they can still have a recurrence of illness, but I think what that points out is that family members do affect the patient with the disorders. And then, as we said before, the reduced family burden, lower stress, and again, I've talked to so many families, and I've seen people through this whole range of reactions from angry, despondent, oh my God, I'm hopeless, to feeling a sense of serenity because they've accepted that they can only have so much an effect on their loved one and they have to focus on themselves. And I think when family members start focusing on themselves, that's an indication they're moving towards recovery, because initially many family members who get involved in treatment do it for their loved one, not for themselves. And that's true also with mutual support programs. If people go to Al-Anon or Nar-Anon or other family programs, often they do it with the idea they want to help their loved one more than themselves. And so some of the interventions, working with patient on the impact, how have you affected your family? As John said, many individual models include family sessions. Encourage the patient to get the family involved in mutual support programs for addiction or mental illness, such as the National Alliance on the Mentally Ill. Provide education, support, and referral. I mean, families need to understand illness. They need to understand addiction as a disease. They need to understand relapse. John had talked about it being a chronic relapsing disease. There's a difference between having a chronic relapsing disease and just what people consider bad behavior or unmotivated behavior. But families aren't going to understand this if they don't get some education. Meeting with individual family members, providing, facilitating, linking to family education groups. And then you have family programs. And just as one example, you have the matrix model. I just pulled that out today. They have 3 manuals, and they have one for clinicians on the group and individual work, mainly group work. They have one manual for clients in recovery, and then they have a manual for family counseling as well, where they have a curriculum they cover, and they educate them and they get them involved, and there's opportunities to share as well. And then the IMR is the illness management recovery model, which is more for the chronic mental illness. And there are a number of studies throughout the U.S. and other countries that show a lot of positive outcomes of that vis-a-vis the psychiatric symptoms and the functioning of the patient and the functioning of the family as well. And then in some cases we might provide or we might facilitate therapy, marital family therapy. But there's a difference between ongoing long-term therapy, which some of the models propose, and just brief family interventions, and both are very important. So the family member without the substance use disorder, understanding and accepting the problem, supporting the recovery of the member with the addiction, adjusting to sobriety, which is not always easy. I mean, I've had people in front of me tell their spouse they liked them better when they were drinking, and then deal with the realities of lapses and relapses. These things happen with these chronic diseases. Family safety, involvement in recovery, reducing emotional burden, and then helping other members get help if needed. I've seen many spouses that were affected in ways that they had a clinical depression that they needed help for. Or you might find children in the same case. They have problems with their behaviors. They, maybe it's dad or mom who has the addiction. And I think this is so important, the focus on self-care, but I think that's the most difficult things for family members to do because they're so giving and caring and loving to other people, they often lose themselves in the process. So John is going to take over for here, and then I'll end with a couple comments on children. So go ahead, John.
Thank you, Dennis. I'm just going to speak briefly on some of the strategies to engage family members from a provider's perspective. And one of the key starts to that is to actually look, if you are a provider, you work for a system of care, is family mission statement or involvement of family. We actually changed our mission statement 2 years ago to include the recovery of family members because we believe that's an integral part of the recovery process. Do you have a family philosophy of care? Is it in your vision? Is it in your mission? Is it in your policies? We were in one of my residential programs years ago. We were trying to boil down the common components and factors of people who graduated this 6-month length of treatment at the time, this residential program. And what we found is one of the key components was involvement in family. Back then in this residential program, family involvement was not an expectation like mandated or a standard of care. But what was interesting is that 80% of the people who graduated had family involvement versus only 20% of the people without family involvement actually graduated. So with such incredible numbers there in utilization of family and outcomes, we changed our policies in our residential program to make it an expectation of treatment that family or significant and significant other involvement would be part of treatment and as core part of treatment as core as individual and group involvement would be. And we found that it had a significant impact on increasing retention and positive outcomes for graduation by pulling the family member in as well. So key to that, though, is right from the beginning of an intake or a phone screening in your agency. Sometimes there's a phone access. People can come in or through their website or just walk in through an intake that when the person from the first phone call calls to ask for help, we in our agency ask who will be participating in your recovery or who in your life is supportive of your recovery becomes a key important statement from the provider's perspective that makes it a given that family members will be involved in the recovery process. And if the person identifies somebody who will be coming in and being part of their recovery, we ask them to please have them bring you to the screening and the intake. There's even a practical liability exposure here where if you have somebody who's struggling and in the throes of addiction, you don't want them behind the wheel coming to your appointment. It's from a safety perspective. It's great to have somebody drive them there. But as soon as they come in, we want them to orient them about the program. We have this expectation of them signing releases to include somebody who's going to participate in their program, so it becomes a given and it doesn't become like an opt-out option. So we do this to have them understand their experiences. It helps families engage in the process, and we even work on doing outreach to connect to the families. And an important piece is we don't take the client's word. Oftentimes, they're not often the most credible self-reporter on the fact that families can't come in, and we reach out. We think it's part of our professionalism to have the respect of calling the family members and trying to include them in the process, and we reach out and try to call them directly to get permission to get them involved in the family process or find out what are their concerns. Again, it comes back to not needing a family therapist to make these phone calls, but just a skilled clinician who understands addiction and recovery, who may even start to answer some of the questions on the phone, such as what is this program about, how long does it take, what's the recovery process, and start to answer questions as they come in of what do I do that may help support my loved one's recovery, what have I done in the past that may have promoted their relapse, and what am I willing to do differently that they need to be able to be empowered and sign up for. So the key is being able to really pull them in and look through a humble lens and not knowing that family as well as they know what the strengths are in that family. So you need to join with them and join quickly. Let them know that you need them, that the therapist becomes part of the team, and respect if a family says no for now and check back with them later to see if that has changed. And again, answer all their questions, but to let the family member know we're in this together and that we are not the experts. They are the experts of their family. They know what makes their family tick. Again, outreach if you need it. Try to stay away from labeling family as resistant or codependent, and be patient, flexible, and accessible, and look for incremental change, and look for what the family would see as defining success as they would measure it. So we try to have the clinicians provide education and support right from the beginning. So the primary goal is to be able to support their loved one's recovery process and not inadvertently undermine it by not understanding what good treatment is and what it isn't. Explore experiences, concerns, and questions, really be able to listen to them and hear what their concerns are, and deal with the challenges facing families, the emotional burden that Dennis spoke of, their sense of they feeling like they're the enabler, and have them reframe enabling in a way that says that they just showed love the best way they knew how with the choices available to them at the time, and have them learn how to redefine love in a manner that promotes their recovery and the recovery of their loved one. Facilitate individual assessments if needed, and help parents focus on their children. So again, reducing the emotional chaos and burden of families is significant. Reducing the anxiety, worry, fear, the anger, resentment, the guilt, shame, embarrassment, the depression and grief. There's more and more now in the field of resiliency that the more we can reduce that emotional burden and stress, the more we can actually help individuals in that family become more resilient and hopeful. Improving communication becomes key in problem solving, having clear communication of what recovery is and how each person can be helpful to each other in their recovery process. Reduce negative interactions in communication. Try to increase positive strength-based communication and support. Solve current problems, and increase family rituals to ground the family in positive interactions in a way that would give them a sense of grounding and hope in the future. Focus on self and family and significant other. That is, again, the concept that the family member's recovery is independent of their loved one, that their loved one can go out again, and maybe 2015 may not be the year of recovery for their loved one, but it doesn't mean it can't be their year of recovery. To start a process of being able to make decisions that meet the needs of their conscience and be able to offer a sense of what's reasonable or what they can do and what they can't with regards to a sense of powerlessness in their loved one's life. You oftentimes hear the expression tough love. My concern is sometimes it comes across as too much tough and not enough love. So a person has to be able to make decisions that they can reconcile, that are reasonable, that they can live with without knowing the outcome of how it may impact their loved one. So again, focus on the family member, manage negative reactions, deal with emotional burden, give them the social support of other family members, and that's what Al-Anon and Nar-Anon does so well, and self-help support and mutual support. The pain doesn't cut as deep if the person realizes they're not alone and other family members have gone through similar struggles. And this is also where they can learn resiliency as well and prepare for the challenges of recovery, both for the patient and the family member.
Yeah, and I would add, I'm thinking about the Bridge to Hope family support program that I attend sometimes. And what's beautiful is if you watch families who go to Al-Anon, Nar-Anon, NAMI, or meetings like this, you will see people who are well-grounded in recovery, who are doing a lot of these positive things. And they may still be living with heartache and heartbreak because maybe their loved one still is using and being chaotic and so forth. But you see their growth, and then you see what they do to help the younger or the newer members as well. And I think that's just a wonderful thing, people helping each other in recovery, because even though we're talking treatment here, we're also promoting the idea of recovery. And then the last intervention is to focus on how do you get parents to help their children, because children should not be forgotten because they are affected by these disorders, as we had mentioned before from the research and from our clinical experience. So they need an opportunity to share. They need an opportunity to be protected from certain behaviors. These are the high-risk behaviors, violence, intoxicating behaviors. And then positive activities and family rituals are very important that John had mentioned. And things that many of us take for granted, you may not have regularly in families affected by more severe manifestations of addiction, for example. Establish some normalcy as much as possible, and part of that depends on the person with the disorder is living at home, and if they're still actively using, then that's much more chaotic. But family ritual is important, doing things together. I mean, if you think of your own families, the things you do together really keep you well connected. Being interested in what's going on with the kid outside and the relationships, that may help prevent them from getting into difficulty, because sometimes kids express their frustration, their anger by getting involved with other kids who are similar, and they get involved with kids that in trouble, and they're more likely to get into trouble. And also having child attend some of the sessions. And I'm thinking, I have a friend of mine, Robert Ackerman, who's written a lot on addiction, the family, and children. And he wrote a book years ago called Same House, Different Homes, where you could talk to two children in the same family, and they have totally different experiences. One's devastated by mom's addiction, and the other is coping quite well. So you want to keep that in mind. And the last point is very, very, very important, is anytime we figure out directly, we've seen the child in a session, or we've heard from mother or father that this child has some kind of problem, some kind of maybe suicidal, maybe very depressed, trouble in school, whatever, getting help for the child with any serious problem, that may mean having to facilitate that, and that is a tremendously helpful intervention, because if you go back to what we said from the literature, a large number of these kids are affected and will have serious problems as well. So we appreciate Tracy pushing us along. We wanted to cover this in about 50 minutes and then open this up for your comments or discussions about what are some of the potential research questions or issues to consider related to families.
Marcella Sabercio, would you like to go ahead and address the group?
Yes, thank you. I am calling from Mexico, and I was very happy to hear all the interesting approaches that were presented today. It's not a question, it's just a comment. I've been working with families in Mexico, both in urban areas as well as indigenous areas, where there are no treatment options, and we have come with a brief intervention program that has been tested for efficacy with very good results. But the thing is that it is very encouraging to see that the families are being recognized not only as the responsibles, as the main risk factor for the development of substance use disorders, but also as the most close circle that suffers all the bad consequences of this consumption. So it was very, very interesting to see this presentation. Thank you.
Well, thank you for your nice comments.
Nancy Hamilton.
Nancy Hamilton. Great job, guys. I didn't know anybody still remembered Robert Ackerman. One of the things that, as I was listening to you, that sometimes with adults we have I don't want my mother involved. I don't to not give up on that just because initially they didn't want their family involved. But as they progress, sometimes they're more open to having families involved.
Yeah, and I think, Nancy, first of all, it's always good to hear from Nancy Hamilton, who's usually shy and doesn't share much.
Exactly.
I think patients fall to the lowest level of expectations. So if you don't expect anything vis-a-vis the family, you won't get anything. And you may have to negotiate and work with them, but you can make a difference in terms of getting them to agree to bring families in. It won't happen 100%, but it can happen a whole lot.
Right. And sometimes you can go for somebody that they trust, who's a little easier on them, like their grandmother or their grandfather or some other member of their extended family that they see as their ally.
Yeah, absolutely. Ally, a confidant, and someone that probably isn't in an active addiction themselves.
Yeah. In fact, in the resiliency research, the resilient kids adopt a functional, healthy family that could be a neighbor and friend's family. And then even if there are no families involved, to be able to be part of a group, kind of the model of self-help support is that becomes a functional family for people. And the same thing for Naranon and Nalanon.
Right. I figure families, whomever you say is your family.
Exactly.
All right. We have Steve Sparenborg, who has his hand raised. Steve, go ahead.
Hi, Steve.
Hey, Dennis and John, thanks very much. I find all of this fascinating. And I wanted to know if there's any way that you could characterize generally the amount of time that a family member or all the family together spends in therapy in terms of length of session, number of sessions, and how often do they do that with the substance abusing family member present in the counseling session?
That's a great question, Steve. And I think some of the minimum expectations of family involvement, whether it's outpatient or residential, is to bring the family into the screening and biopsychosocial process and assessment in the process, and then determine whether or not that family would benefit from family education, multiple family therapy sessions if you have it, or individualized family therapy for that specific family, but having an initial session in the beginning and then a check-in session midway for a progress report for how everyone's doing in treatment as a minimum. And then again, a very key piece is post-discharge for discharge planning at the very minimum, a third session to allow for a real responsible discharge plan to get the buy-ins of the family members of what they can support and not. Because if the family can't create a supportive recovery environment, it does inform a treatment recommendation for sober housing or recovery housing or extended care.
Yeah, and Steve, one of the answers to your question, too, is some of the models have discrete numbers of sessions. It may be 12, it may be 20, 24 over 6 months or a year. In the family therapy models with mental illness, for example, psychiatric illness, usually the more severe manifestations like chronic schizophrenia or bipolar illness, recurrent major depression, would often stick with families for a long time, for at least a year, if not longer. And they might include a combination of what's called family psychoed workshops, where you bring a family together for 3 hours, 4 hours, 6 hours, and you give a lot of education, have some supportive discussions, and then you have them return for multifamily group sessions. Then you also have some individual sessions. So there are a lot of different models out there. The Matrix model, if I recall, had 12 group sessions that each focused on a topic, and then they had some individual family sessions as well. But because of the nature of behavioral health reimbursement systems, you're seeing less and less sessions. In fact, it would be interesting to go to managed care companies and find out how many family sessions are they paying for, and I hate to say it, you would probably see not that many. Yeah. The other thing I would urge you to think about, too, this is unrelated to treatment, is the next 10 brochures you get in the mail for conferences related to mental illness, addiction, or both. Look to see how much focus is on the family, and I bet you it's very, very little. And if you look at we appreciate you all being on today, but you look at our attendance, 40 people. We've had in other topics, we've had 125, 150 people. So, this is a comment on where we're at.
There's a question in the queue. Richard Radocia, are there any funding resources that you are aware of to help nonprofit agencies implement a research project of evidence-based family intervention strategies? John or Dennis?
Well, I can start, and then Dennis probably has some resources as well. But in our state, we have our single state agency does small grants for implementation of evidence-based practices, and again, that does include evidence-based family models. SAMHSA oftentimes has opportunities to keep an eye on some of their funding for integration of family into treatment. And then NIDA has implementation science that probably Dennis can speak more of, opportunities for researchers to be able to study the impact of implementing family as an evidence-based practice in a community treatment provider.
Yeah, you could look at foundations too. Foundations may support a project related to what you're talking about. And then someone had mentioned about they use. Laura had mentioned they use CRAFT, and I'm sorry, I lost it. Yeah, wanted to know about therapists or programs that are using alcohol behavioral couples counseling. What you may check, Laura, is the Veterans Administration Medical Center. They have a website where they have evidence-based practices that they expect to be used in different veterans hospital programs. However, having said that, it doesn't mean they are using that, but you probably could find some who are using that approach. But again, what you're all going to find is you have these good evidence-based interventions, and they're not used a lot.
All right. Well, that will have to be the last comment. Thank you, Dennis and John, for facilitating this very important discussion. If others are more interested in having additional discussions on this topic, we can arrange for that in another session. And then afterwards, there will be a survey, so please tell us how you felt about your experience on this session. And I welcome everyone back next month on June 10th to discuss emotional brain training and substance use disorders. And we have an industry expert here that will be our guest speaker for that session. That will end our discussion today. Thank you.
You're welcome.
Thank you.
Thanks, Tracy. Thanks, John.
You're welcome.
Thanks, everybody. Bye.
Thanks, Tracy.